My name is Jim Pavlik, and I am the Program and Policy Analyst at the Behavioral Health and Wellness Program at the University of Colorado Anschutz Medical Campus. In my capacity here at BHWP, most of my work is in assisting organizations to adapt their workflows for a variety of clinical quality improvement initiatives, mostly focusing on chronic disease prevention and control, with a particular emphasis in tobacco cessation interventions. Today's presentation is titled Improving Outcomes, the 5 A's in the Health Neighborhood. The health neighborhood model is one that BHWP has been developing for a few years now. And I don't know that we want to get too bogged down in semantics today, but I do want to take some time to explain kind of what that means just a little bit, and because it does frame how we should be understanding the interventions that we'll be recommending. And in my opinion, there are two primary ways to think about what we mean by the health neighborhood. On the one hand, seen from the medical perspective, this is the further evolution of what was initially called the patient-centered medical home, which then grew into the patient-centered medical neighborhood, which is sort of where medical continuity of care programs are aimed right now. Seen from a different vantage point, the public health perspective, this is the realization of the concept of the social determinants of health and what has recently been called public health 3.0. What we're talking about is community-based work with the kinds of community entities that public health has partnered with in the past. Faith-based organizations, community-focused nonprofits, community advocacy groups, schools, other governmental programs, etc. But what's been missing from this earlier conceptualization of community-based work is a systems change component, borrowed from recent shifts in focus within the medical care delivery space. The purpose of this first module, which will continue as a theme for the remainder of the series, is to not think of communities as the place where we deliver our programs or the people who those programs are designed to help. Communities aren't destinations for health delivery, they're the sources of it. So it's worth taking a moment right now to talk a little bit about the content that's going to come next. Those of you who were team members during the first phase of the community of practice will notice a lot of overlap with the first module of that round, titled An Introduction to the Health Neighborhood. Those of you who are community partners and for whom this is your first webinar, this may be the first time you're hearing of the health neighborhood. There's no need to worry, because in the introduction, if you want a further exploration of the topic, you can find the archived version of the introduction webinar. But for those of you who don't necessarily need another hour on this topic, I'm gonna summarize a little bit of what we did in that particular webinar, just so that we can lay the groundwork for what follows afterward. So for those of you who are attending from the first round, there is going to be some overlap at the beginning. Stick with me. We'll get to the new stuff right afterward. Which does lead us to this, the 4 objectives of today's webinar. So we will review the case made for the health neighborhood in the first module of the first round of the COP. And again, if you want more than that, you can find the archived version. We will then move on to reviewing the fundamental building blocks of a person-centered tobacco cessation health neighborhood, which are those clinical best practices that can be dispersed throughout a community, provided they are connected by a supportive structure. And finally, as we near the end of our time together today, we will discuss how we identify and define a health neighborhood for our community of care so that we can best place ourselves as caregivers within it. One thing we have to understand is that not everyone who uses an addictive substance becomes involved in the criminal justice system. And not everyone involved in the criminal justice system struggles with addiction. This is also true of mental illness and poverty, broadly speaking. However, the overlap between these various populations is significant enough that we can't really ignore it. The fact is that many factors that put one at risk for addiction are shared with eventual incarceration. And the relationship between addiction and incarceration is causal, complex, and bidirectional. As we discussed in the third module of the first round, the evolution of drug courts already recognizes this complexity, and they've started to focus their attention on taking care of drug court participants' psychosocial and health-related needs as necessary components for achieving long-term abstinence from drugs and delaying or preventing future involvement with the criminal justice system. This evolution of the drug courts, which is also being adopted in the county's jails and prison systems, and is more and more being adopted by community corrections as well, is not isolated to what is being called therapeutic jurisprudence. This understanding of sources of health and those risk factors that are shared between poor health, health behaviors, and criminal behavior is coming at us from really every direction. It is now a commonplace observation that the United States dedicates more money per person to healthcare than any other wealthy country, and for that, it is rewarded with middling health outcomes or worse. In fact, over just the past couple decades, certain indicators of overall health, like childbirth mortality statistics, show a nation that is not only being outpaced as other nations improve, but is performing worse than it had previously. That is, in an absolute sense, getting worse. In their book, The American Healthcare Paradox, authors Bradley and Taylor make a compelling case that at least part of the vast and widening discrepancy between US spending and outcomes is due to America's concept of healthcare as medical care, disassociated from social services. Where Americans outspend their European peers for hospital, doctor, and specialist visits and drugs, we dedicate very small amounts to developing a robust social safety net guaranteeing basic housing, income, and food security, as well as treatment for mental health conditions and substance abuse. When adding medical and social services spending, America's health outcomes aren't paradoxical anymore. Our average health outcomes are correlated with our average spending levels. Estimates vary, but most models only attribute between 7 and 10% of a person's health to their doctor. But addiction to any drug, including nicotine, is a product of an individual's biological constitution, their genetics, their metabolism, dietary inputs, age, gender, and racial and ethnic heritage. It's also a product of several other factors, including the health behaviors of their family and friends, their income and educational levels as children and as adults, and their occupations. Their encounters with communal living facilities like jails, prisons, and residential substance abuse treatment is also a factor. While 99% of individuals with a daily smoking habit began before the age of 25, admission to a communal living arrangement where smoking is permitted is a common place for non-smokers to start after young adulthood is over. And approximately 5% of non- and ex-smokers will begin smoking upon admission to such environments. It's also a product of the policies that influence their actions and those of their peers. These include organizational policies, municipal regulations, county and state laws, and the national tobacco control landscape, all acting in concert to encourage and discourage certain choices. It's entirely possible and probably likely that the best thing that the United States can do to improve the health of its residents is tighten up and expand national, state, and local tobacco control policies. However, such large-scale changes often court controversy from ideologically opposed voters and, because they're effective, major commercial interests that would rather not see giant swaths of Americans reconsider their tobacco use. In any case, those are population health initiatives, and they are outside the purview of today's discussion. We are focused on person-centered approaches. Population-based approaches and individual-centered approaches do share a certain set of values, and agreeing to, recognizing, and working toward shared goals is absolutely necessary. There is no population health without helping individuals within that population in getting healthy. Moreover, there is no wellness where hunger, pain, drug addiction, and poor mental health are prevalent. Population policies can help support the work done at the individual level, and individual-focused work can help generate the support for better policies over time. The criminal justice system is a complex one with deep penetration outside the confines of the incarcerated environment. Those entering arrive via unique life courses with unique risks: poverty, unstable housing, underperforming school systems, toxic environmental exposures, and others. These risk factors not only contribute to their chances of being involved with the criminal justice system in the first place, but other overlapping outcomes as well. And in order to best serve the individuals that come into the criminal justice system, the communities that they come from and will return to reduce recidivism, to reduce the cost of inmate care, and to serve the broader community comprised of all of us, we can leverage the complexity and the penetration of the criminal justice system to narrow important health inequalities that persist among the most vulnerable of already targeted at-risk populations. And we can do this by translating the criminal justice system's multiple points of contact into multiple points of care, and using some or all of these as linkages outward back into the communities that those individuals will eventually return to. Each of you likely already knows where you are in the sequential intercept model developed for SAMHSA several years ago. Or if this is your first time hearing of it, you can likely pinpoint your position with a quick glance at it right now. What we want to focus on today and over the next several months together is dispersing as many of the evidence-based clinical interventions as we can across this model and tying them together in such a way as they appear as the seamless provision of a comprehensive set of services to any individual going through this system. In an ideal world, the intervention described here, building a tobacco cessation health neighborhood, would be done in conjunction with national, state, and local level tobacco control expansion on the one side, and a vast education and training initiative aimed at clinicians and other care providers on the other side. But in the absence of such changes, intermediary approaches like the health neighborhood are, as they have often been called, quote, necessary to save those that our policies leave behind. Said another way, our fundamental building blocks here are the care that's delivered, in our case, the evidence-based tobacco cessation interventions, which we will enumerate shortly, the places where that care is delivered and the actual people that provide that care, and finally and critically, the processes that connect care sites, or to be more blunt, the referral processes that connect individuals from the care provided at one site and the related care provided at another site, and the data sharing agreements between those sites so that the experience of care is a positive one. There are a lot of texts out there about systems and about what systems are, and pictured here is a definition of the health neighborhood that I think is clear and actionable. A health neighborhood incorporates a broad array of services and supports organized into a coordinated network, integrating care planning and management across multiple levels that is culturally and linguistically competent and builds meaningful partnerships in order to help individuals achieve wellness, no matter how that individual defines it for themselves. Anytime you see a coordinated network integrating care planning and management across multiple levels, you're seeing a system. Ideally, the system is culturally and linguistically competent and at least aims at building meaningful partnerships. These two factors are aspirational and are always incomplete projects. The first part is the necessary component of systems. Cultural appropriateness and relationship building transform a healthcare delivery system into a system of care. Facilitating health systems change does often involve adding services to our systems, but the bulk of the work is helping partners organize those services into a coordinated network. Which is to say, we want you to feel confident in your ability to perform the elements of tobacco cessation treatment that you or your organization has the capacity to perform. But we also want to encourage you to look up and downstream from your position on the sequential intercept model to develop tobacco cessation partnerships for the individuals you are hoping to help. So having, I hope, successfully argued for why we should be working in the health neighborhood, I'm now going to move on to discussing its mechanics. All of our work will be structured around the 5 A's, and we will return to this concept again in a future webinar. For our purposes, we will consider the 5 A's to be a set of functions, the goals of which can be met in a variety of different ways. Which is to say, if we think of the 5 A's as a structured set of functions rather than as a single intervention per se, its role will make more sense. And into that structure, we will fit the evidence-based care to the best of our capacity to do so. And that evidence-based care is detailed on this slide. These are the services given an A or B grade by the United States Preventative Services Task Force. So theoretically, these services should be reimbursable by health payers as preventative services as governed by the Essential Benefits section of the Client Protection and Affordable Care Act, aka ACA, aka Obamacare. Those of you working in or with systems seeking reimbursement for care almost certainly know that this coverage is not treated in a uniform manner by all payers. Nevertheless, these are the services or products we'd like to make sure are available for our neighbors, and the more of them that are available, the better. Once one or more of these are established, we can move on to supportive work, like educating the public on their existence and establishing referral protocols between service sites and so on. To this list of evidence-based best practices, I would add screening and assessment that is assessment using a validated instrument. These are not alone sufficient to motivate a quit attempt or impact its success. However, they are essential components of a responsive tobacco cessation workflow, and they can be separated out as dispersible functions of the health neighborhood. I would also like, for the purposes of the health neighborhood, to look at the word counseling. This word causes a lot of confusion, so I'm not going to propose that what I say next conforms to the word counseling in all of its contexts. I only want to talk about how that word is meant in the tobacco cessation and reimbursable services world. Health systems tend to define tobacco counseling to involve four primary components: a discussion of the harms of tobacco use, a discussion of the benefits of quitting, a discussion of the tobacco user's triggers and barriers, and finally, a treatment recommendation. And this last is normally operationalized as at least a recommendation for FDA-approved pharmacotherapy. These conversations are classed into 2 degrees of intensity, a 3 to 10 minute version, and a greater than 10-minute version. Notice that this description does not include anything therapeutic. No mention of a therapeutic modality, no mention of processing or recovery, or anything like what a licensed clinical social worker, an addictions counselor, or a psychologist might do with a client. And I bring all that up to point out some things. Professionals outside of therapeutic spaces often balk at including counseling into their practices because they think they're being asked to perform therapy, a task that they are often untrained to perform professionally and might find personally uninteresting, maybe even unappealing. But providing health education is far more familiar and an agreeable task. I also want to reiterate that the harms of using and the benefits of quitting is an educational function that can also be separated out and performed by anyone. In non-medical settings, we might call that tobacco education rather than counseling, but the function is the same and can play a role in calibrating perceptions of risk, normalization, or promoting successful quit attempts. So, 2 slides ago, we listed the objects of our cessation system. The 5 A's provides the outline of a structure of how and when to link individuals to those objects. Some things I want to point out is that the 5 A's is an evidence-based framework, and it is applicable across disease prevention and treatment efforts. This is important because if you're working with individuals with other chronic conditions, for example, diabetes or high blood pressure, you can adopt these same structures across their issues. There is nothing magical about this acronym. The functions described are critical ones, and as such, any effective chronic disease-related effort is performing one or more of these services, even if they don't call them by the same names. As you seek allies in providing a robust set of tobacco cessation services, redefining their chronic disease work in 5 A's terminology can help you develop a crosswalk between their work and the specific tobacco cessation functions that you might like them to perform. Many of you are probably used to hearing about the 5 A's in conjunction with the 2 A's and an R. And many settings have adopted the 2 A's and an R model. That is, A, asking if a client uses, A, advising them to quit, and then R, referring them to services rather than providing any additional cessation-related help themselves. The 2 A's and an R model is also an evidence-based practice. It is less intensive than the full 5 A's. Even if you provide the most intense tobacco cessation intervention, we'll call it multi-session individual counseling, it's still likely that you won't provide all of the supported tobacco cessation services, not all of the evidence-based ones that we listed 2 slides ago. It's also possible that you'll want to support a tobacco cessation attempt through addressing other aspects of the client's wellness, including processing grief or loss, stress or anger management, connecting the client to supportive services like SNAP, etc. At some point, it is assumed that the client's needs will exceed your capacity, and you should refer to someone with that expertise. So while the remainder of today's presentation will focus on performing all 5 A's, it should be considered understood that as a client's needs exceed you or your organization's capacity to address those needs, you will make relevant referrals. As you consider to whom you will make referrals, you should keep a few things in mind. The first is that the service should be accessible to the consumer. And here we mean an expansive sense of accessible, which would include whether the client can actually physically get there and whether it's affordable and available to them. The referral should also be designed to address the client's needs. A client who has already set a quit date, for example, should not be given a brochure on how to do so. And it should also meet the client where the client is at vis-a-vis their capacity. An individual unable to participate in a psychoeducational group should not be directed to one. The service referred to should also be adequate to address the consumer's dependency level. We may think that sending a severely addicted individual with a single self-help brochure meets the standard of something is better than nothing, but we should keep in mind that an unsupported, unsuccessful quit attempt that ends in failure may induce suffering in the form of both physical withdrawal and damage to social network. Such negative quits could delay, perhaps indefinitely, the next time the individual seriously considers making a quit attempt. That is not to say you shouldn't provide bare minimum services. The emphasis here is on making sure that as part of the intervention, you set the proper expectations. To the greatest extent possible, you should truly trust whichever service providers you send individuals to. The more actual interaction you have with those sites, the more likely you'll be able to make that referral with enthusiasm. Enthusiasm can reframe a future struggle as one with a potential positive conclusion, which may make any struggles seem more bearable. The bottom line here is that believing you can quit and believing you are supported makes a huge difference in whether someone succeeds or not. So I do want to discuss briefly what the 5 A's are, keeping in mind that our ultimate goal here is to make sure that everyone in our care receives each of these functions while on their path toward nicotine dependence recovery. I'm going to go through this fairly rapidly, both because I'll be repeating the steps a few times today as we build the basic version up to the neighborhood systems level, and because other resources exist from us if a deeper exploration is required. ASK is basic screening. We don't want to deliver a tobacco cessation intervention to anyone that isn't exposed to nicotine or to tobacco smoke. So our basic screener should be something simple like, do you use any nicotine-containing products, including cigarettes, e-cigarettes like Juul, or any smokeless product like Chew, Dip, or Snus? Also, are you regularly exposed to the smoke or vapor exhaled from such a product at home or at work? One practical consideration here is that as a matter of best practice, we do want to ask everybody every time we see them. The primary rationale here is that motivation to quit changes pretty rapidly, and we want to make sure that we are connecting people to cessation services and resources whenever their motivation to engage is at its highest. And the only way to know that is to ask frequently. A secondary but important reason we want to assess nicotine use regularly is that sudden changes in the volume used can be an indicator of an upcoming mental health crisis, or it can be an indicator of a sudden change in the overall wellness of the individual. Important things like food shortages, increased life stressors, or lack of sleep, things that can impact a person's ability to get or keep a job, or that may contribute to future involvement with law enforcement. After ASK, we want to make sure to inform the individual that the best thing they can do for their health and well-being is to quit their tobacco use. This message should be delivered non-judgmentally and in a way that may resonate with them. For example, tying it to other goals like sobriety, housing, employment, child visitation, that kind of thing. Next, we want to assess their readiness to quit. Those who are uninterested in quitting require no further engagement. It might be worth asking those individuals if they would consider accepting any educational materials, but for the most part, after someone claims they're not interested in quitting, the best course of action is to let them know that if they change their minds, you are ready, willing, and able to help them in that endeavor, and maybe remind them that you will ask them again the next time you see them. If they are interested in making a quit attempt, we need to either provide the right services at the right intensity level ourselves, or we need to connect them via referral to such services. And we do that by exploring the strength of their dependence, the nature of their relationship with tobacco, and any barriers to quitting they may have. If you are referring to services, then these steps may be very short. If you're providing counseling, as we defined it earlier, then it may be a bit longer. Because I have said previously that the 5 A's is a structure, it's worth highlighting what I mean by that. As we can see on this slide, The results of our second assessment and the assist phase determine which and how many of the United States Preventative Services Task Force recommended services the individual should be connected to. Those services are telephonic counseling, like the Arizona ASH line, group support, individual counseling, peer support, and medication-assisted treatment. The second assessment is the assessment of the level of dependency. Validated instruments like the Heaviness of Smoking Index and the Fagerstrom test for nicotine dependence can provide a recommended minimum level of nicotine replacement therapy or bupropion. The final A in the 5 A's is arrange, by which we mean scheduling follow-ups. How many follow-ups you think the individual might need, how frequently they occur, and how long you continue to follow up with them can all be determined by that individual's need, or, as it will likely be the case for you, as long as the client is assigned to you. Basically, follow-ups should be used in 2 major ways. One is just to check up on the client's follow-through with referrals and their progress with those services. They can also be used to troubleshoot the quit attempt itself. What things are working, what challenges or barriers have emerged, what isn't working, etc. Having explained what the 5 A's are, I now want to begin exploring how to adjust the 5 A's from a high burden intervention for a single person to a low burden intervention for a team. Since I'll then be recommending expanding this concept across the health neighborhood, we should all have an agreed upon notion of what the unexpanded version is. So in short, in the classic version that I just described, a single person will ask the client if they use, this is basic screening. After screening for tobacco use, if the client says they use, then the same person advises the client to quit and then assesses whether they would like to continue talking about this issue. That is, if they are ready to either receive a referral or education on the topic. I'd also include here an actual assessment of dependence. And then finally, assisting the client with their treatment and then arranging for follow-up. While in general, each of these tasks are actually quite low burden, single individuals are very busy, and nothing here with maybe a few exceptions requires anybody with a specialized degree. Although obviously tobacco treatment specialist training in motivational interviewing, or general experience in recovery would all be pretty helpful. As such, we can scope these acts downward to the highest level practitioner necessary. And frankly, as I mentioned, much of this work can be done by almost anybody in the clinic or out in the community for that matter. We use the framework pictured here to conceptualize the 5 A's across an entire clinical experience, although in its broad strokes, this same model can be applied across nearly any site where a person receives services or products of any sort. Still, I won't be going into any depth on this slide. I'm only using it as a way of showing that the 5 A's, if you think of it in terms of functions, are easily translatable from the single provider version already shown across an entire clinical experience, with the front staff, for example, in this version, doing the screening role, maybe an MD providing the clinically relevant advice to quit, a nurse practitioner performing the assess services, a peer navigator doing assist, and maybe even arranging for follow-up. So, now that we've explored the functions of the 5 A's and introduced how those functions can be dispersed across a workflow, I want to introduce the concept of dispersing the 5 A's across the entire neighborhood. In the 2 versions of the 5 A's already presented, we were talking about helping individual sites add or improve their provision of the 5 A's to find services. A slightly more complicated but common variation are the continuity of care issues involved when one site makes a referral to another site. And in this world, this often takes this takes the shape of a provider referring somebody to the ASH line. In an ideal world, this referral has been made with the client's agreement and has also, and that provider has done a minimum amount of expectation setting regarding, for example, when the client will be contacted and how long the calls will take. The provider will also want to have established a relationship with the referral site, the ASH line in this case, in order to set up a persistent feedback loop so that the provider is empowered with the information necessary to make adjustments to the treatment plan given the client's level and quality of interaction with that service. But what's possible between clinics is also possible between non-medical sites. We've already seen this between traditional medical sites and medical adjacent sites like pharmacies and dentist's office. We also know that getting non-medical sites to refer to the ASH line is possible. And once we know what our goal is, to direct neighbors to trained providers of cessation services, or when possible, to provide those services themselves, the range of potential partners becomes quite large. An incomplete list would include other government agencies and departments, including criminal justice and schools, or other social service operations like libraries, homeless shelters, and multi-unit housing. We can also include faith-based partners. And we can include retail sites like grocery stores, chambers of commerce, banks, and so on. Finally, each of these partners create a neighborhood map that is unique to each neighbor or class of neighbors. So as our goal is to treat people and not maps, as we develop a neighborhood-wide strategy or find our place within one, we want to design our target intervention sites around the neighbors and not strictly around the geography of the area we designate. These are the services that a nicotine user needs in order to have their dependence accurately seen, assessed, and treated. Look at the individuals in front of you, both as a set and as individuals, and think of their course through the criminal justice system from the time of their initial encounter with law enforcement through holding, hearings, trials, incarceration, probation, parole, and think of your place in this timeline. What functions on this list have likely been done or could be done before you see those individuals? For example, some prison and jail systems are already screening for tobacco use during clinical assessments at the start of incarceration. Many are or could be screened again upon community reentry. If you're in the drug court, health needs and drug dependency are often assessed as part of those programs. Could tobacco use assessment be added to that process? What services are or could be best addressed somewhere further downstream? For example, if part of the person's court-ordered treatment involves regular visits to a therapeutic case manager or drug counselor, could nicotine dependence be unproblematically added to their treatment plan? What processes can be put into place so that each individual receives each of these functions at the most opportune time and delivered by the most skilled provider who can perform them? I'm going to close with a case study from round one as an example of a simple intervention that nevertheless highlights our emphasis on connections as the fundamental building block of systems. This will be a short recap of that case study. For a further exploration, you can see the recorded webinar, Drug Courts as Health Neighborhood Partners, that's on the COP resource site, or email me for the article that's listed here. This is our picture here. This is a story of a successful structure for matching clients with non-medical needs that I ran across in a publication called Quality Improvement for Drug Courts, Evidence-Based Practices. The substance abuse facilities in this study already use the Addiction Severity Index, or ASI. The ASI screens for the severity of addiction, as its name applies, but it also screens for other features that may be connected to the individual's use of intoxicating substances, including their legal issues, their housing situation, medical, employment, family, social, and psychological needs. It does not screen for tobacco use. Many drug court employees are being mandated, typically by a state or some other governmental or organizational body, to use this form, but they did not have a mandate to do anything with the information they were collecting on this fairly long form. And as such, many rightly felt that this was pointless busy work. The hypothesis of this case study was that if the case managers connected the information that was gathered on the ASI to a resource that could be provided to the client, then the treatment services would be quote unquote better matched. So were they? They were. But there were other outcomes as well. Not only were the referral recommendations better, the uptake of those recommended services was higher, and clients were less likely to leave the treatment programs early. And there was an interesting side effect. Although I say interesting, it makes perfect sense to me, is that the case managers who were instructed on how to make these kinds of referrals and given the tools to do so, stayed in their jobs longer. I'll let you draw your own conclusions, whether that was a statistical anomaly or connected to the intervention, and if so, why? So that is going to wrap up my comments for today. Before closing and moving on to questions, I just want to repeat that a recording of this webinar will be made available and hosted on BHWP's website.